Hi, I'm Dr. Marilyn G. Klug. I'm an associate professor in population health, and I'm a methodologist, statistician, data miner. So today I'm going to be covering the methods and analytical approach to the STRIDE paper on preventing fall injuries. They want to know, is individualized tailored intervention going to be effective? We'll begin with the trial design. This can help you understand if there's any bias in their selection of the data and also who the results could be generalizable to. They begin by looking at 10 sites that had 162 practices. From the 162, they used something called cluster randomization to choose just 86 practices, 43 to be interventions, 40 to be controls. The clustered randomization means, yeah, we're going to randomly choose them, but we're going to make sure that they're balanced in terms of the size of the sites. You don't want all large sites and interventions and small and controls, or locations. You don't want all rural control sites or urban interventions. The other thing they looked at was the subjects in each. If there were 2802 subjects in the intervention and 2694 in the controls, they're not going to be exactly the same because you mesh by number of sites, not by number of subjects. And then you have problems because people may die or withdraw from the study as time goes on. So the final count was 24 or 26 interventions and 53 controls. They did a power analysis. The power analysis said they were going to need 6,000 people. So they were about 80% of the target. But they also did a follow-up on that and realized, okay, our power is still going to be up in the 0.8 range, so we're okay there. Another part of trial design is the participants that are there. You want to make sure that they've chosen participants that aren't outside the population that needs to be studied. That's why they only chose people with specific ages. You don't want people that were too young. You didn't want people living in nursing homes. You didn't want people who were advanced in dementia. You didn't want people who couldn't speak English because the instrument was in the English language. The intervention model itself was defined in two ways. If you had the intervention, that means the nurses would come in and do the assessment, the recommendation, the individualized care plan, and implementation of it, a follow-up, and the subject had to look at a webinar. If you were in the controls, all you got was a webinar and a pamphlet. Another important thing is, what are the variables you're going to be working with? Specifically, let's look at the outcomes. These are the variables that you want to measure, your dependent variables. They had a couple versions of falling. One was a self-reported fall, because the people could check in a box that yes or no, they had a fall, how many falls in the past month. The serious fall, that was one that was actually documented by a healthcare professional that yes, they fell and it wasn't good. The third type of outcome they looked at was the adverse event, and this was if they had a hospitalization or a death during this trial, and that was considered, much worse than a fall. They also added covariates in the model. These are variables that you add in because they may affect the relationship between are you a case control and are you having an event. And some of these could be demographics like their sex, age, race, education. Others are healthcare factors like how many diagnoses they had, medications they were on, did they have fractures, were they have fear of falling, things from the actual survey that they gave the person. So what statistics did they use to answer the questions? First off, the main focus was the survival model. Now, survival doesn't mean death. In this case, survival model means just time to a bad event or a fall. It could be the simple fall or the serious fall. So the question was, do controls have a fall faster than the intervention group? Are the intervention group's falls delayed over time? Now, that's just done with a Kaplan-Meier curve or a Cox regression. But you need to go deeper than that. So they did a sensitivity and interaction test where they looked at how other variables could affect the difference in this timing between intervention and controls. Okay, was it different for younger people than older people when the first fall happened? They also looked at the cumulative incidence, which is basically the number of falls. Is that different between the groups at different times? They had to use the maximum likelihood or the Poisson regressions this time because cumulative incidence is count data. And you would expect most people to have 0, 1, 2, 3, say 4 falls. And then as it goes further and further up higher number, there's fewer and fewer people with that number of falls. It's a skewed distribution. So that's why they use the Poisson for that. The next question that's kind of a subset after the survival question on the falls is, what's the rate of adverse events? Is this intervention helping to keep people from either being hospitalized or from dying? So they had to look at those questions, and they used the Cox model for the deaths, and they used the Poisson model for hospitalization because that's also the number of models. That's what they used for the statistics to answer their key questions.